Good evening, everyone. My name is Kathy Bennett, and I am the co-chair of the Northumberland Learning Connection. And it's my pleasure to welcome you to the final session in our Digital Future series. Before we begin, I would like to offer a land acknowledgement. We respectfully acknowledge that Northumberland County is situated on the traditional territory of the Mississauga Anishinaabeg. We recognize that Mississauga Nation as the collective stewards and caretaker of these lands and waters. Their enduring responsibility to preserve the health and integrity of this land continues to guide their efforts for the benefit of future generations. Now I'm delighted to introduce tonight's speaker, Gemma Postill. Gemma is the education co-lead at the Temerty Center for Artificial Intelligence Research and Education in Medicine. She is also a fourth-year MD PhD candidate at the University of Toronto's Temerty Faculty of Medicine. Currently, she is completing the PhD portion of her degree in clinical epidemiology at the Institute of Health Policy Management and Evaluation. Her research focuses on long-term, patient-centered prediction of traumatic injuries in older adults. This evening, Jenna will guide us through the rapidly evolving field of digital health, from virtual care and wearable technologies to artificial intelligence and electronic health records, with a critical eye toward both innovation and equity. She will explore how digital tools can enhance care delivery while also addressing the ethical and practical challenges they raise. Please join me in welcoming Gemma to the podium.
All right, thank you. So believe it or not, my PhD is in AI, but this is the fanciest tech I've ever had in a presentation. So shout out to our guy over here. I've heard he's famous around this part, so. With no further ado, I'll begin the talk. We're gonna talk about digital health, its promises, progress, and pitfalls. But I want to begin with what is TCARM and why am I here? There's many people probably more qualified than I to speak about AI in healthcare, but I'm here because of my work with TCARM. So the acronym is there, Temerty Center for Artificial Intelligence Research Education in Medicine, but it's a lot to keep repeating, so I'm just going to call it TCARM. So what is it? Well, in 2020, we had a very generous donation from Lord Temerty. He's not just Mr. Temerty, but Lord Temerty, which is a cool fun fact. And he added a lot of innovation to the entire medical school, but his asterisk clause in the donation was that we established an institute that extended across multiple disciplines and focused on how we get AI into healthcare. So where are we now with this organization? It's grown a lot in size and scope. We have multiple branches. Dr. Mohammed Mamdani is the director. And within TCARM, we have our education group, which I co-lead along with Laura and Abhishek, as well as we have our infrastructure team, and they're devoted to developing the infrastructure we need to integrate AI into healthcare. We also have our research team. They fund lots of innovating research projects. And we also have a community team. We've made lots of impact, and in fact, Toronto and Canada is on the map in terms of the progress we've made in AI in healthcare. And so it's a really exciting time to be working with TCARM and to be working in this field in general. Today, we're going to talk about more than just TCARM. We're going to talk about what is digital healthcare. We're going to focus on AI, but I was warned that this is not your average group. This is a very advanced group. You've all had AI training, so this will look more like a formal test. Be prepared. Then we're going to talk about some cautions with digital health and how we're also working to overcome these and where we're going next. Why this talk? Why now? So I did my training in public health, and Walkerton was most famous for its water crisis. But today, Walkerton has another claim to fame. Many of you probably saw this photo or a version of it earlier this year when they had a new family doctor arrive at the town, and there was a crazy lineup in the middle of winter in a big snowstorm of people wanting to get enrolled in that family doctor's clinic. So digital healthcare offers, I think, a potential solution to this. And we're going to go through what is digital healthcare, and I'm hoping to sort of explain why and come back to this idea at the end. But our healthcare system has a lot of amazing qualities, but there's also a lot of demand, and we don't necessarily have the human resources to meet all those demands. And tech and digital health is emerging as an opportunity to address that supply-demand mismatch. So to begin, what is digital health? There's a lot of terminology in digital health. You might hear e-health, and that's referring to any digital tool that's supporting electronic healthcare delivery. That's the E in e-health. There's m-health, which you may have heard of. This is healthcare delivered on a mobile device. There's telemedicine. So this is medicine that's delivered remotely, not just over the telephone, also things like video applications. There's wearable tech. Many of you guys might have like an Apple Watch. That's kind of what we're referring to. And then there's AI in healthcare. So digital health is not just AI, and that's the point I'm hoping to make with this slide. There's lots of elements of it. In terms of my expertise, I have no idea how the Apple Watch works. I don't know what it does with my data, but I know a lot about AI. So we're going to focus on AI in healthcare for most of this talk. So raise your hand if you know what AI is. Okay, great. So I'm going to get you to define it. No, I'm just kidding. But that's good. I'm glad everyone has a good basic definition. I think it's important because there's a lot of like random definitions about what AI is, same with what is digital health. And to align us all on one definition, AI broadly refers to the science of computer algorithms that perform a human cognitive function or intelligent function. So pop quiz, since you know a lot about AI. Who invented AI? Fun fact, I did not know what generation came before baby boomers, and so I had to Google it. So I was like, how have I never heard of the name of this generation? They're actually called the silent generation. So that makes sense. So I'm gonna get you to raise your hand. Who invented AI? Was it 1, the silent generation, 2, baby boomers, 3, Gen X, or 4, millennials? Okay, so raise your hand if you think it's 1, silent generation. Okay, some votes. Boomers, did the boomers invent it? Okay, got some votes. Could it have been Gen X? Okay, a little bit less votes, but still some votes. They work very hard. Anyone voting for millennials? Oh, we got some votes for the millennials. Okay, I like it. So we're a bit spread, a little bit heavier towards 1 and 2. It was actually the silent generation. So AI, we're having all these talks right now, but it is actually, it's new, but it's not that new. So the term AI was coined in the 1950s in Dartmouth at an academic conference where they said, what if humans could do, or what if machines could do human things? And we called it artificial intelligence. So that was when there was the first paper published with this AI concept. Now, AI didn't just linearly become more popular and linearly become better. There's been things that they call AI winters. So a little bit of excitement, and then the excitement diminishes. A little bit more excitement, a little bit more progress, and then you don't hear much about it. Similar to, I think, how things work in politics. But the reason AI is really taken off, and when I say taken off, like this is a plot of the number of publications around AI per month. So there's a lot of progression right now. And that's happened because of a few things that have kind of come all together. We have data sources that are big enough to train these models. We have the computer power, we have that infrastructure needed to run these programs. We also have high quality algorithms. So there's a very cool algorithm that was developed in Toronto and it has just won a Nobel Prize. So we're making lots of great progress in Canada, as I'm saying. And we also have the digital health infrastructure and as well the leadership and sort of desire for innovation and change. And so all of that has happened to create this opportunity where AI is really making impact, but it's something that we have been looking at and we have been studying for a very long time. Why innovate? Why is it taking off in healthcare? Well, like I said, there's all those things that have been created such that AI has improved, the data, the algorithms, but we're also seeing a need for it. It's not just being done because it's kind of cool and interesting, although I do think that and do it in my bedroom, but there's also the pressure. We have an aging population. We have healthcare workforce shortage, as demonstrated by the first photo. We have a rise in chronic diseases, so how we care for people doesn't look the same as it did before. We're managing multiple diseases. People can be very complex and live a long time in good health with those conditions if managed properly. But this is a very different healthcare paradigm than we had 50 years ago. And we also have rural and remote access gaps, which I'm going to touch on at the end. So we've got lots of specialists located in a very concentrated area in Canada, and in theory we have universal care, but it's not always accessible by everyone. And so we're seeing this pressure to innovate. How can we get healthcare to these people or these people to healthcare without physically moving them? So some examples of what that innovation looks like, there's telehealth platforms, there's wearables, like I said, there's remote patient monitoring. So Holter's one example where you can take it home and it is a real-time ECG. You have electronic health records, and then you also have artificial intelligence tools, which we're going to talk a bit more about. Briefly, some benefits that we think that you're going to get with digital healthcare. So there's enhanced access, like I said, that physical distance. That's one of the things that we're trying to address with digital health. There's also personalization of care. So I'm going to come back to that in a second. But we're getting real-time monitoring and patient-driven care, or data-driven care. And then we're also getting greater patient engagement. If patients are able to have the data and understand their health patterns themselves, it's no longer the same paradigm of a doctor saying, this is what you must do, and you don't really understand why. You have the tools and resources to engage better. So what is personalized medicine? It's going to come up a few times because this is one of the interesting things about AI. Previously, with a lot of our healthcare research, we study populations with diseases, the whole population, and we create care guidelines based on what we see works well for the population. This kind of makes sense. In general, you tend to treat people very well. But you don't treat everyone always the right way. So one really good example is antidepressant medications. We have a clinical pathway that usually starts with the type of medication called SSRIs. There's different types of SSRIs. Some work better for some people than others, but we don't have a great way of determining like which one is best for you right off the bat. So often what physicians do is they'll try you on the first one. And if it doesn't work, come back 3 months later and we'll try you on the second one. And if it doesn't work well, we'll try you on the third one. And so a year later, you're still struggling with depression and you visited the doctor about 20 times. That doesn't seem very efficient and that doesn't seem very personalized. So part of the goal with digital health is to move towards that personalization. So we're no longer treating populations, but we're treating individuals. And one of those elements is using not just information from the public and then synthesizing it and being specific to you, but also using your own information and your own previous healthcare experiences and using that to inform your care. So that is why we are at artificial intelligence. But what really is AI? So that was the brief definition, introduction, but we're going into the level 2 concepts on what is AI. So I'm hoping to dispel some myths. So one of the things that we do within our role at TCARM is we teach physicians about AI. And usually when I ask them to define AI, they say, it's like ChatGPT. I'm like, that wasn't really a definition, but okay, thank you. So ChatGPT is like one branch right here. So AI is a lot bigger and broader than just ChatGPT. And I'm going to focus on a few other branches of AI so you can get an understanding that the limitations and cautions for each one are actually quite different. So we'll start with machine learning, which is at the top. That's my expertise and what my PhD is focused on. So AI, I said, is this field of study where computers are imitating humans. Okay, great. So then what imitation or what function is machine learning? It is a subset of AI that reflects the ability of computers to learn automatically. So usually, with a traditional epidemiology science study, you would have a hypothesis, and you would test that hypothesis. But you are explaining to a computer what the hypothesis is, and it's telling you if it's right or wrong. With machine learning, you give the computer the answer, and then the data that goes in, and you say, can you figure out can you draw a path from the input to the output? So machine learning is automatic learning. Deep learning is a subset of machine learning, and this is what we won the Nobel Prize for in Canada. And it essentially just refers to a more complex algorithm. So where is ChatGPT in all of this then? If ChatGPT isn't machine learning, what is it? So ChatGPT, as I mentioned, is a type of NLP. So it goes down this natural language processing task. And it's specifically a generative model. Oh, I guess I didn't need to point to it. So generative AI versus non-generative AI. The distinction is important, largely because of where we are in terms of innovating in healthcare. Generative AI creates answers. We talked about a great example earlier of if you needed to create a recipe book or gardening, you could say to ChatGPT, I have these 5 ingredients in my fridge, and I'm trying to come up with something to do. Could you give me ideas? And it might not have ever seen that question before, but it is able to generate an answer based on the input. But that answer isn't what you gave the model to learn in the beginning. It's creating. Non-generative AI is what we've done a lot of innovation with in healthcare. That's what we're seeing already being used to care for patients. So an example here is ChartWatch, which is being used in several of the Toronto hospitals. And what this AI tool does is while you're in the hospital, if you're admitted, it is watching your vital signs. And it's using patient information as well, so it knows a bit about your age, your reason for admission, all of that, comorbidities. And then it's looking at how your vitals are doing. And it interfaces with the pager that physicians carry, and it'll flag an alert, like we have somebody in bed 24, Susie, you should check on them, they're at high risk of deteriorating. And so now physicians in Toronto are getting these alerts, and so when they get a high alert, they'll then go and check on the patient. And the alerts are getting a bit more fine-tuned such that they then suggest next steps. So go check on Susie and order a complete blood cell count. And so then they can do that. Now, non-generative AI, though, is not making up an answer. It's not saying, tell me how Susie's doing, or what is her feelings? I don't know, something like that. It's using patterns that it's already learned. So it's that type of machine learning that I showed you where you gave a model the data that goes in and then the answer that comes out, and it finds out what the pattern is. And then it uses that to make predictions going forward. So for example, maybe in the example that I've given of Susie in bed 24, it has seen that somebody with this reason for admission, with this age and this comorbidity has had a prior pneumonia while admitted. And so that's why the flag is going off. But it's not hallucinating, it's not creating an error. So the cautions of the two different types of AIs are quite different. if you're a visual person, this is what I say, but now written. So generative AI creates new content, and you are concerned about hallucinations when using it. So you should read it, but you should read it carefully. Maybe when it created the recipe for your ingredients, your 5-ingredient cooking recipe, it also said add olive oil. And you're like, I don't have olive oil. Like, where did you come up with that? But it just assumes. Versus non-generative AI is making predictions off of learned relationships. And so you're not concerned about it just making up that they're going to have a pneumonia. It's using patterns from previous examples. But you are concerned. Non-generative AI is not perfect. We'll come back to this a bit at the end, but you want to make sure that the data it learned those patterns on is good and that the patterns it learned are also good. Otherwise, it's not going to work very well. So we'll come back to that concept in a minute. But quickly on hallucinations, because I said the word and I want to make sure that we all kind of know what I'm talking about. So a hallucination is something in a natural language model or a large language model that contains false or misleading information, and it's presented as facts. This is not a myth. So a myth is an error that's in the training data. So for example, an apple a day keeps the doctor away. I've had an apple a day. I've also had to visit the doctor. Like, I don't think it works. Mistakes are violations in rules. So if you said, Joe was diagnosed in 2020, in 2010, in 2020, he has the condition for 6 years. That's a mistake. That doesn't make sense. You and I would read that and be like, you calculated wrong. And in fact, language models are notorious for not being able to do math very well. I'm the opposite. I can't spell, but my math is okay. So hallucinations, though, they're a different type because let's say you're a physician and you asked ChatGPT to write a consultation for James. Now, this is very tiny text, but you said in this sidebar right here, write a consult note from a cardiac surgeon for James who has an MI. So then ChatGPT creates this note. Joe is a, in brackets, year-old male with a significant past history of list conditions, in bracket, who presented to the hospital, bracket, with date, bracket, with symptoms of chest pain radiating to the left arm and jaw associated with diaphoresis and shortness of breath, blah, 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 blah. So I didn't tell ChatGPT that Joe had chest pain radiating down his arm. I also didn't say he had shortness of breath. I also didn't say he was a male. Maybe it's Joanna who goes by Joe. I don't know. And so these would all be considered hallucinations. They're things ChatGPT is essentially assuming. So we have to be careful with that in AI. Now, I want to flip back to the non-generative AI as well. One thing to think about with this, and it's the same can be true for generative models, but like I said, AI can learn relationships between the data given to it and the data that comes out of it. In healthcare, we primarily used fixed AI models. So what does this look like? I give the AI model data, it tells me what the answers are, and it's frozen. I evaluate it, I see how well does it work, is it very good, what kind of mistakes does it make, does it always get the answer wrong, maybe on women who are between 20 and 25, we can learn a lot about it, and it's fixed, and then we use it in healthcare. This is similar to any other healthcare tool. We know how the microscope works, its parameters doesn't change, it works the same. We know how a CT scan, it works the same every time. But with AI, and what they think could be the future of AI would be continuous learning models. So they're models that when you come to the hospital, it would then see, oh, there's this new presentation, and it would update its parameters based on you as an individual arriving to the hospital. Why would this be beneficial? I think we all saw COVID, for example. It was kind of came out of maybe not nowhere if you're a population health expert, but it definitely surprised the healthcare system. And we saw the presentations of illness change. People stayed at home longer. They only came to the hospital when they were way more severe. And so the model would then update its parameters and learn how to predict and direct care more appropriately to this new scenario. But this scares a lot of healthcare officials and patients, because if the model's changing, could it be getting worse? So right now, we're primarily dealing with fixed AI models. They're trained, they're frozen, and then they're used. But I'm presenting this concept of continuous learning models because we might see it moving forward. So I think the takeaway from AI level 2 is that it's not just one thing, it's not just that one definition. AI is many different things. There are many different tools and many different approaches, continuous learning, fixed learning. And so we have to think about each AI tool a little bit differently and critically appraise it according to what the tool is. So this leads me to cautions with digital healthcare and how we are overcoming those challenges. So what are the challenges we face? I thought of 4 that I really want to share with you guys. The digital divide, who is left out, privacy and data protection, clinician fatigue and digital burnout, and bias in AI algorithms. So quickly on the digital divide piece, I think one of the things that we're seeing, and it's a current research problem in Toronto, is that all of these models are being developed in academic institutions, and their performance is being evaluated as such. But these institutions look very different. The Emerge doc runs the model and sees the patient needs this, then can direct the patient to the specialized cardiac specific vein repair surgeon. They quickly get the surgery, they go home, all is good. This looks very different in a rural community. And so we're now doing a lot of deployment of these models in different contexts. And what we're seeing is people, how they use healthcare services differs tremendously from urban environments to rural locations. Often people come in with illnesses at more severe stage, and the model does not always work the same. And so that's, I think, our biggest challenge. I'm going to touch on education of physicians at the end, but I think we need to be educating our rural and urban physicians differently on AI. There's privacy and data protection, and this is definitely a concern. And so ChatGPT, for example, is continuously learning. So it's not fixed, and that's why people caution you from putting too much personalized healthcare information in there. Certainly you could say, I am feeling these symptoms. I think that's not a bad thing to do at all, to ask ChatGPT as you would Dr. Google, but it would be, details, personal details that you wouldn't want to add into something like that. In terms of clinician fatigue and digital burden, a lot of tech people deployed, for example, these alert devices, and they were like, this is going to be great. It's going to ping you every time you have a patient at high risk of deterioration. You're going to love it. It's going to be really helpful. And so now you're a clinician on the ICU floor. You can imagine all your patients are at high risk of deterioration, and you're constantly getting pinged, and you're like, this is not that helpful. And so we're now in the AI world moving a lot to, a lot of focus is being directed towards user interface to make sure that the right people are getting the right alerts. Because, for example, is it the nurse that should be alerted in that context of deterioration? Maybe it's not the physician. Maybe what we need is a different unit to be alerted that this patient would be better off to be transferred to them. And so we're addressing those challenges. It's interesting because we're addressing them as we're also deploying AI, but that is the beast of healthcare, which is a moving ship. Okay, lastly on bias in AI. So we're more than halfway through. I thought you needed some shock factor for, interest, waking us all up. Okay, Amazon And Jeff Bezos is pretty smart, so it's crazy that they made a mistake. But I'm going to air out a mistake they made. In 2018, they were, early on the AI bandwagon. They deployed an AI tool to essentially triage resumes. So imagine it's like, to me, I think of it as triaging at the Emerge. You go to Emerge, you check in with the nurse, and then they say, okay, you come this way. You have to wait 8 hours. You don't want to be the 8-hour person. But they wanted to do that with resumes. So they thought, why do we have to read all of these resumes? What if we just read the best resumes? I'm like, oh, that kind of makes sense. And they could focus on actually interviewing maybe more candidates, less time just reading resumes. People do a lot of BS on resumes anyways. I get the rationale. So they said to the AI development team, our current employees are phenomenal. We want to hire people like we got a great team, and these are all the people who've applied in the past. And we didn't hire them, so they probably, weren't as good as our great team that we have right now. So if you could teach the model how to decipher between all those resumes we rejected and all the ones we hired, that would be perfect. So the model did that. It did that very well. But the problem is that the model learned not the right relationship that they had intended. So the way some of these natural language models work is they focus on individual words. We're getting better at focusing on words in context, but in 2018, they did focus a bit more on individual words. And what the model noticed was a lot of these applicants that are unsuccessful have the word female in their resume. So it'll be like president of the female yoga class or the female business leadership chapter. And all of the ones that were successful just had president of leadership chapter. And so the model was like, this female word's not so good. They should not be hired. And so when they deployed that model, it did not perform very well. Sure, it identified resumes similar to what they had, but when they dug into it and they were like, why are none of these women getting through? Like, this is a great resume and it was like rejected. What was wrong with it? And they looked at it and it was like the AI model saw the word female and was like, oh, not a good candidate. So now this model was actually being used, but then they scrapped it and they said, that's not what we're trying to do here. We'll, back to the drawing board. So I don't know what they're using right now for resumes, but I think this is a really good example to show how sometimes AI, it's a very powerful learner, but it doesn't always learn the right things. So this is what we call algorithmic bias. Now, it's a new concept in machine learning. Kind of within the past 5 years, it's really taken off as we've started to understand a bit more about these algorithms. The definition is kind of debated, but largely what you can think of is it's a systematic error in how it works. So it's working consistently wrong in the same group, and as a result, the output is biased or not fair. So there's many different causes of why does that happen? And I present these, there's actually no test on this slide, but the others maybe. I present this not as a take notes, you need to know all of these, but more to emphasize the fact that we have done a lot of evaluating in the field of machine learning and computer science, and we are starting to get a good understanding of what some of these errors are, and importantly, why they arise. We haven't fully been able to understand this. Same with natural language processing like ChatGPT. We don't fully understand why it makes some of the mistakes it does. But this is where a lot of research is being focused. So some of the reasons that Amazon model might not have worked is because the data that they gave it wasn't great. And this is probably the case. They didn't give it any examples of successful females that had the word female in their resume. Okay, so that's maybe why the model went wrong. It might also have been poor label quality. So label is what the machine learning world uses as the term for output. So maybe what they told it was the answer or the output wasn't really great. So that kind of makes sense. Their current employees were probably fine, but they were subjectively hired, so who's to say they're really the best candidates? Like, how do we know the right answer? The same can be with like diabetes, for example. If a model is predicting whether or not you have diabetes, when it learned that relationship between people who had had it in the past and those who hadn't, were we using people's self-report? So me just saying, I have diabetes. Were we looking at their medication records? But what if somebody has diabetes and they're actually not using any medication right now? That's very possible. So there can be problems not because the machine learning is bad, but because the data we give it either to go in or the answers we give it aren't great. Also, underrepresentation. So this is what comes up when we think about deploying a model that was developed into Toronto to somewhere like Cobourg. Are the illnesses the same? Are there certain problems people have here, or certain reasons for certain healthcare problems that we have here different than in Toronto? And if that is the case, then the model just hasn't had an opportunity to learn those relationships. So when it is deployed into a location like this, you would see the performance drop, not because the model didn't learn good relationships, but because it's not being applied in the use case that it was developed for. And then the other thing is it can learn incorrect relationships, and data can change over time. So the data set shift is like the fancy term that they're using to explain why the model wouldn't work in COVID. Like our data and the people that we're seeing, the illnesses that we're seeing are different. So naturally the model wouldn't work. Another famous example, I guess not famous yet, but maybe it will be, is St. Michael's Hospital. It's a big academic institution in Toronto. And they have a great in-house AI team. And they're developing all their models at St. Mike's, and they're running them at St. Mike's. And they work really well. And they've actually been shown to save lives. I'm going to show you a few of them in a second. But one of the things that they did, which is kind of interesting, and it's about the data set shift, is when they added their electronic health records, so they just switched to Epic, which now has all the patient data instead of charts, which, believe it or not, a giant downtown Toronto academic hospital was using paper records until like January. And when they switched to Epic, what they did was they paused all of their models, because they recognized that how data goes into the model is very important in determining its performance. And so they've reevaluated that and seen with this new electronic health record that the models are still working and they'll be redeployed. But important example to point out. So this is what I said, but again, put visually. If you have mislabeled data, you're going to have poor predictions. And that's because the model is learning between things that aren't great. So we can't expect the model to figure out those relationships. And my kind of takeaway, if you remember anything from all of those examples, is that with a supervised machine learning model, so we're not talking ChatGPT right now, we're talking those fixed models, they're only ever as good as the data you use to create them. So we need better data. This is an example of one of those in healthcare. And I want to save a bit of time to where we're going next, so I'll kind of quickly describe it. But it was a similar example of to the Jeff Bezos Amazon one, where in the States, they deployed this model. It was actually being used. It was supposed to be a flag in the family doctor's electronic health record. So if you visited your family doctor and you had a lot of complex comorbidities, and they wanted to redirect you to a specialized, complex care program where you could then see like a nutritionist and another care provider, all sort of one place, one time. And so the flag was supposed to go off in your health record, and then the family doctor would refer you. Again, this is a great idea for a model. The problem was they started to use it, and they noticed that any of their black patients had to be twice as sick as a white patient for the flag to go off. And the physicians in the clinic were like, this doesn't seem right. Like, it doesn't seem to be working. I don't know if I like it. And it was cool because they raised the flag. So they reevaluated the model. And what they realized was that their outcome, or their definition of like somebody needs specialized care, was based on the cost of their healthcare in the previous year. Now, as you can imagine, especially in the state system, your cost of care is only how much you can afford, and also therefore a measure of access to care. So it wasn't so much that they weren't in need of care, and that's why they didn't have those care visits and the high cost of care, but it was that they couldn't access it. So this is fun fact. So race was not a variable in that model. The model did not look at whether or not the patient was Black, white, it didn't have any access to their name, no ethnicity data, but yet the model was kind of racist. So just food for thought. In Toronto, we have a really cool team who's created this tool, Appraise AI, and the goal of it is to help kind of systematically look at all of these issues that can cause the model to be biased. And it's come up with this checklist scoring card. And so they're now using it more and more as they're creating and publishing these models to say, what quality is my model? Which is good. So we're not making those same mistakes, we hope. Where are we going then if we're not making those mistakes? Should AI replace clinicians? Okay, raise your hand if you think yes. No. Oh, we have two half hands. Okay, so that makes one vote. All right. And then, so I'm assuming the rest of you are like, no, please, like, keep my clinician. Yeah, is that what yeah? Okay, I'm getting a lot of nods on that. Yeah, I think that's where we're going for a number of reasons. So the first is that with AI, we're seeing that it is not necessarily better than clinicians. There's been a number of studies that put up an AI model and a clinician or multiple clinicians, and they compare who makes more mistakes. And they make the same number of mistakes. But what they've noticed, interestingly, is they actually make different mistakes. And we expect them to make the same mistakes because the AI is trained on human data. But they make different mistakes. Why? Because a lot of the cognitive errors we make in medicine are based on things that have been well studied, but like recency. So for example, if you had just seen, a patient come in with metastatic cancer, that might be more commonly on your brain, even if it's not as common in your community. AI, depending on the type of model, but most AI doesn't have that same recency bias. It has learned those relationships on the population. So this leads to the concept of sort of automated versus augmented care. And clinicians and patients don't seem to like automated care that much. Automated care refers to healthcare processes that are entirely done by machines, so very minimal human involvement. There is a role for it, I'll come back to it, but in general, that's not where we're headed. Where we are headed is this idea of augmented care. So this refers to the use of technology to support healthcare decision-making that's done by clinicians rather than the replacement of them. And as I've said, that clinicians and AI devices themselves make different mistakes. So if we put them together, the hope is that they're kind of correcting their mistakes. And in fact, there have been some studies that have looked at that, and they've shown that that is the case. Because often the mistakes we make clinically are the ones that we're sometimes uncertain about. And so having that AI prompt us can help us rethink. This is a study, if any of you are really interested in reading studies, that just came out 2 weeks ago, so it's very hot off the press. But it shows exactly what I just said, and it's an interesting concept because they've seen it in multiple different settings with multiple different models, that AI is not better than doctors, largely because it's trained on information doctors knew, but they make different mistakes, so together they're better. I have thought to myself, why would AI and clinicians be the same? Like, couldn't AI get better, be better? Couldn't we teach it to be better than humans? And one of the issues with that is exactly what I'm showing you right here. So imagine this is me, except my hair's gone a little crazy, so it don't look as put together. But I have a patient in front of me, and I see this person. How am I supposed to know what is wrong with them? I have to ask them questions. They have to be willing and trust me to tell me the answer and what they're actually feeling is bothering them. I have to take the right tests. I have to read the tests appropriately and not make any mistakes in that, and essentially extract all of that information using like vision, sound, sight, all of those different senses. Versus AI often has the information already pre-formulated, extracted, tabulated. And so AI performs well because the information is already extracted. And so when humans are able to extract the right information, which is key to those studies that I've shown, is they give the AI model and the human the exact same information, they make the same, they perform at the same level. So the problem is information extraction. So then what we need to think about to use AI appropriately is where is that information already extracted, and how can it be used to improve system efficiencies? Because ultimately, we don't want that line that we saw at Walkerton. We would like the emergency department rooms to look like this. Has anyone ever seen an emergency department look like this? I don't even think the caretaking staff would have seen the emergency department look like, I don't think it ever looks like this, unless it's closed, which is not a good case either. So this would be the goal. But an interesting AI model that's kind of about to be deployed at SickKids, I can't remember exactly when their go live is, but it's been sort of well validated at this stage, is they want to improve the efficiency in the emergency department room. And what they realized is that many kids sit for a very long time with their parents, and they don't need to actually sit for that long if we already got them the tests they needed, so that when the doctor arrives, they have already had the imaging they need. Because right now, the doctor arrives, asks you all the same questions that the nurse did at the beginning, and then says, you should have this test. And then you wait, and then you wait more, and then you wait a little bit longer, and then they come back with the test and everything, and you're on your way. But they took the use case of appendicitis, because the symptoms are very much the same in all presentations. You present with pain in the bottom corner of your stomach or abdomen, and then you have a fever, all of those symptoms, and it's pretty easy. We should order a test. We should image your abdomen. But yet we wait, the child waits all of that time. And so they have automated that, because that is an example where the data is already extracted, it's already taken, the nurse already has those vitals and signs, and it's a way where we can improve the efficiency. Now, interesting thing on this model for those who really like math, like me, so they had to decide with this model how many mistakes they want it to make, which is kind of an interesting question, because the model could perform with 100% accuracy in detecting all instances of appendicitis. But the trade-off would be it would also overdiagnose. It would think that, just to err on the side of caution, let's image everyone. I mean, that doesn't sound that bad until you tell a radiologist this. And they're like, no. Unless you're giving me an AI model to read all of these images, I don't think so. So there's lots of sort of debate that goes in between, like, well, where should we set the threshold? And what they did with this model was they found kind of the right point at which anyone who we were very certain has appendicitis, we would send to the automatic imaging pathway. And if we were unsure, we weren't going to say, like, no, you don't have appendicitis, but we were going to say, all right, we'll have the doctor come in and sort of do, like, regular care. They'll check you out. They'll decide if they also want to get imaging, which is kind of cool if you like data. So now we're sort of at this role of, I think, academic leadership, clinical leadership, in terms of getting the digital literacy so that patients, clinicians, everyone understands. whoa. Was it me or was it? It's okay. I do find it quite warm in here. I should take off my jacket like all stripping layers like this. And yeah, so I think that I'm really excited to see you guys learning about AI, digital literacy, because this is the future. And it's quite possible, though, that you're more advanced than your physician, because we're doing some physician education, and now there are some very brilliant physicians who are like designing their own algorithms, so this doesn't apply to them. But there are many who do not know anything about AI. And that's what my role is in the daytime when it's bright outside. In the nighttime, I hang out here. But we're focused on the question of what education do physicians need and what liabilities will they have. Because this is a major concern that comes up. If the AI makes a mistake, whose fault is it? Is it the patient for wanting to? Is it the hospital for saying you should use it? Is a physician for using it? And the mistakes can be small, but the mistakes can be big. And there's something that we need to think about from a physician side, but also a patient side. Like if we're increasing efficiency, what's the risk threshold that we're kind of all as a community willing to accept? Now, I have potentially a hot take that I would like to share with you. I think that where the healthcare system really needs improved efficiencies, improved healthcare performance, and improved access is in smaller communities. I think that's where AI has the potential to make the biggest change. Now, in order to do that, that would mean individuals like yourselves and physicians who live in those communities actually need more than basic skills. They need to be AI proficient or even AI expert, because this is where, in theory, digital health will make the biggest impact. So I mentioned liability as well on the last slide, and it's something that is very much not it hasn't really been sorted. We don't know who is fully liable. If we follow the state's model, the physician is always liable. That doesn't really create a lot of incentive to uptake new technology. But we are also having some good innovation and movement at the government level. They've created a regulatory system to regulate software as a medical device. So they have a group of people who look and appraise those models and can give AI tools that designation. Some of the ones in use, though, don't have it. There's debates on whether it's needed or not and how much. We also, as of this year, now have an AI Safety Institute. So I heard at one of the last sessions you had very deep conversations about how AI can change humanity. And this institute also has those discussions. And part of the reason not all models have that software as a medical device like label, almost like a Health Canada checkmark, is because they're developed in-house. So they're not commercially sold, so they don't need technically an approval. It would be like your own herbal remedy kit that you use. There is debate in the AI community about what's better. I told you the limitations of taking a model developed in Toronto and then putting it here. It's probably not going to work as well as it does in Toronto, which would, in theory, perpetuate health inequalities. And that's because the people look different. The frequency of illness looks different. So the probability of predictions are different. So there is a movement to a lot of people developing their own AI solutions and using common pathways. So this model worked here. We'll try something similar, but we'll use our own data. These are many AI devices that are being used in Toronto. ChartWatch I walked through in detail at the beginning. They're forecasting the volume in the emergency department to improve staffing. Instead of a random 8 hours wait time on the dashboard, they're being more precise and they're estimating better. Predictors of hypoglycemia, emergency department assignment tools, so they're just automating some of these administrative tasks that take a long time because they want to make sure they have the right staffing and expertise in each area of the emergency department. And ChartWatch, they evaluated it, and those alerts, as annoying as they are, seem to be saving lives. They noticed since the implementation a 25% reduction in the mortality, or the unanticipated mortality, which I should say is not overall mortality. And the last example I'll give in Toronto is Assist TBI. This one they're hoping to scale across Ontario because of the great performance. So when an individual falls, they can hit their head and have a brain bleed. Most people will image their head, particularly if they're sort of above 65s, you're more likely to have a bit of a brain bleed. But this creates a lot of images. And just like a regular bruise, not all of it is worrisome. But sometimes it is. And so we err on the side of caution. We do a lot of images. And we imagine with our imaging that it looks like this. The doctor is like, and thinks a lot. And he goes, and decides what to do. But in reality, it looks like this. They're in the middle of a different surgery. They get a call. They go over. They look at the image. And then they're like, I think it's this. And then they go back to this really technical surgery they were doing on someone else. Now, you wouldn't want this if you were the one on the table, if you were the one whose head is looking like that, if you were their sister or friend. So that's not a great situation. But what they're hoping, similar with the sick kids one, is to improve the efficiency. So if there's very obvious, like, oh, that's not like worrisome at all, let's not send that to the emergency, to the neurosurgeon. Or if there's ones that are also very serious and need urgent escalation, why do we need to go through this whole like care process? It's just those ones in the middle where we're uncertain. So they've developed this model in Toronto, and they're silently deploying it, which means that it's running right now in the background. Clinicians don't see it, and we're comparing how the model predicts versus what they are normally doing. And this is to make sure the model's working without deploying it and like potentially having any adverse side effects. But the goal is that this will actually help improve the universal aspect of healthcare, because we would have an individual in Coburg who hits their head. Right now, the image is sent to a neurosurgical specialty center. There's only, I think, 7 or 9 in Ontario. So probably somebody in Toronto or Kingston is reviewing the image. But what if we can sort of automate and improve that so that people are getting care tailored to their image, but also efficiently? So that's what they're doing at St. Mike's. And I think in terms of what's on the horizon, what's next, predictive tools, AI-assisted diagnosis and triage, those examples I mentioned, digital-first care pathways where you sort of start digitally and then move towards a human or provider, and definitely a shift in sort of how in medical education, both providers and also patients. And that's sort of where I want to end off. I do really think that it's important that patients are as equally informed about AI, what it can do, its limitations, because it will be used in your care, and emphasis on your. And my final thoughts, technology is a tool. Its impact depends on how we use it. Same with AI, same with ChatGPT. And I think the cross-generational dialogue is very vital. That's why I pointed out that AI was actually developed by the silent generation. You guys have very important insights, and the future of the care needs the past's wisdom. All right, thank you.
Chip, 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 chip.
Okay, we're going to take some questions now. Do you want to stand there? Is that comfortable for you? Or you
Sure.
can sit in the little special chair. If
Oh,
you want,
that's like a fireside chat?
Okay. Kathy's got a mic, or we'll get a mic. Come get a mic. And questions? Okay. Go ahead.
No.
Oh, okay. Well, can I start with one?
Yeah.
You know that thing you can do where you take a picture of your mole?
Mm-hmm.
Is that sort of similar to the neurosurgeon thing where they take a picture of the brain
Yeah.
blade?
Yeah.
Seems
Similar technology. So what's cool about the mole one is that, and this is where, now, I'm not saying AI is better than humans, because I don't agree with that. But what AI does in instances like looking at the mole picture is it examines pixel by pixel, and that's how it notes it. So it maps the circle, but unlike a human, we're like, yeah, it's kind of right. Like eyeball, it's about the same. Still a circle, not a circle. Oh, it's kind of an oval. It's actually like calculating the pixel color, and it doesn't just know the, 20 colors women know and the 6 colors men know. It knows the whole spectrum of the rainbow. So I would say arguably like there are use cases like that where AI is actually slightly better. Now, it has to be trained obviously on images that humans have labeled. So we say that's a bad mole, that's not a bad mole. But it looks at them in more detail than we would clinically.
I'm trying to picture the interface between the human patient and the system here. So I'm not sure if I'm going to be sitting in front of a keyboard or a microphone or what, and I'm sitting there thinking, golly, autocorrect invents all kinds of stuff when I just write an email, so how's this going to work for me?
Yeah, for like a dictation.
So it was nice that you pointed out the importance of having a clinician work in teamwork with this, but
100%.
do you need a human who understands this to interpret between the people, or how does that work?
Yeah, and I think it would depend a bit on the technology. I think the clinician that understands AI is really important for creating the model. And whether or not like a regular clinician or patient needs somebody sort of in between who understands the model and the model, I think to me depends on the user interface. So things like the pager that goes off and says like this patient is at high alert and this is what's next. If the information is being sent to the right person and they know sort of the limitations of the model, I think they have enough information to act on that. But the human in the loop that understands AI, like where are they needed? Is that kind of also the question?
Kind of quality control. And
Yeah.
me as the patient, who am I talking to? The Star Trek computer and saying, computer, I want to know great tea?
Yeah. Yeah. And it would depend on the model. I'll give you the example of Unity Health, which these are all their models. So they noticed, so if we have like a brain bleed detection tool that's giving an alert every time that we see a bad brain bleed or one that needs review, and then anytime there's not an alert, the patient's fine. They were like, okay, well, what happens if the model stops working? Like, I'm a clinician, I'm assuming no answer is good, but like, what if no answer is like the model doesn't work or the system's down or I don't know, cyber attack or something like that. And so they, and I would say other institutions are kind of adopting a similar mindset. They have a 24/7 on-call, not IT team, because they get very upset if you call them IT team. They're apparently a different level, a different domain, but an AI model team. And so they're constantly evaluating how good that, I want an Earl Grey tea and the actual Earl Grey tea you got. They're like doing consistent quality checks to make sure that no model is going offline and also that the performance is not dropping in the models. But with something like ChatGPT, nobody is. So, you say to ChatGPT, I'd like a recipe for Earl Grey tea. And it's like, I would take Worcestershire sauce and however you say that word. That's the hardest word to say in my mind. But whether it's giving you the right answer or not, there is no one monitoring that and watching that. And that's where some of the concerns arise. An interesting example that will have a lot of monitoring and we can kind of, from a societal perspective, watch is that Kids Help Phone is going to pilot sometime later this year a AI chatbot, and they're hoping to obviously have it make very positive impacts, but they're going to do a lot of very close monitoring of every conversation and assess for lots of different risks. I will say, though, that in terms of generative AI, especially like those language models, we don't fully understand necessarily all of their limitations. I think one of the good things is we've deployed them early and we're getting lots of user feedback. but one of the bad things is we also don't know, which is why a take-home activity is tell ChatGPT when it's wrong, because it is continually learning. So if it does say, Earl Grey tea, add ketchup, those things like that, be I don't think so. Yeah.
Oh, we have a question here.
Okay. Thank you so much for your presentation. I'm actually a bioethicist. I do healthcare ethics.
Amazing.
And I was wondering what kind of ethical oversight is in place at your institution.
Yeah, that's a great team.
So glad you're here.
So we actually lost our gold star ethicist to Australia. They poached her, Melissa, but we have a department that looks at ethics around the hospital, including of AI. I think that one of the questions and concerns, so they're a great team, they're very highly involved, from conceptualizing the idea to the end. Because I think ethicists obviously make a huge impact in terms of the actual models deployed, but also in terms of thinking about those things. No ethicist would have probably seen that cost model and been this is gonna work. They would have raised their hand and been guys, what are you doing? And so I think having that expertise early on is very important, and something that at our institution we've learned and realized. I was gonna say something else about ethics. Oh, the one side where AI ethics is growing, and I would say is still a shortcoming, is how to evaluate the models when we don't have the data. So in Ontario, those of you who are data nerds will know there's not the best race or ethnicity data in a lot of health data sets. So with that model, they were able to assess how well it was working on black and white patients because they had that data. We don't always have that data. And so the question becomes, do we not deploy a model that could save lives because we haven't evaluated on subgroups? Or do we wait and evaluate it? Or so I think that's the biggest challenge in our local context.
Hi. Also, I'd like to thank you for your presentation. Very interesting. I wonder about trying to trap data that's sort of self-reported. So somebody falls and injures an arm. Mm-hmm. One person might say my pain level is 3 out of 10. Somebody else might say it's 7 for the identical pain, you know. Or you start saying, well, occasionally I have a sore neck, not every day. And then they say, how often? Oh, 2 days a week. Well, in fact, you have a sore neck 4 days a week. And somebody over here says 2, and they have it once a week. How do you normalize any of that to understand it or use it?
Yeah, that's a good question. It's probably why I would never put number of drinks per week into any model, because you're rounding up or down, I don't know, but it's not the right number. It's a huge problem because, like I said, garbage in is kind of garbage out in terms of machine learning models. Most people right now are veering away from self-reported data for that exact reason. That's most people. I'm the random person who comes to Coburg on I don't know what day of the week this is, Wednesday? Thursday, my project that I'm kind of beginning in July, a different part of my research is looking at severe injury outcomes. But when you ask patients, what outcome would you like me to predict? They're I'm oh, dead or alive, right? Next month. They're no, I want to know how happy I'm going to be 3 years, 5 years from now. And you're what? I didn't learn anything about that in any of my math training. So I was oh dear. But we're actually going to use really cool data from Australia, because after someone is severely injured, they have a really cool program that calls you at 6 months, 12 months, and 24 months after your injury. And they say, how are you doing? How do you feel? What is your function like? All of these things. And so we're going to try and develop a model that from the time of a fall or breaking an arm or severe injury can predict how you will feel at 24 months. So I'll let you know. It might not work because, like you're saying, I think people veer away from those like subjective models and subjective endpoints. They're also very hard to evaluate whether or not you got it right moving forward because, you know, those millennials are not as tough as like they once were. So like feelings change over time. Like, but yeah, I think. I hope that answers your question by saying I don't know yet, but invite me back next year and I'll tell you what we found.
Gemma, can you talk a little bit about the robot for old people idea that we've all heard about? You know, like a stuffed animal or something for a patient with dementia or things that can help people age in place better?
Yeah, there's a lot of really cool tools for that. I don't specifically know too much about robotics. That's a branch of AI that I'm like, ooh, well, that's interesting. But I don't know very much. I think that right now we're very, very good at AI for specific tasks. Where we're heading is more, they call it like generalized AI. And so AI is performing like multiple functions instead of just predicting one thing or diagnosing things on an image. It's able to like move physically. It's also able to interface like in a chat GPT sense. But yeah, I don't know too many details other than that's where we're heading, but we haven't fully done that yet.
I gather from what you're saying that there's a great need for standardization of input data.
Mm-hmm.
Is any attempt being made to do this?
Yeah, that's a really good question. So it's interesting because they need standardized input data for better AI models. They're using AI to standardize input data for AI models, which is kind of like a very roundabout loop of like, what? But right now we have, I was actually just talking to somebody at the Ontario Cancer Institute for Research, and what they were saying that they're doing is, everybody, writes their cancer data with different column names, and they have different thresholds for what is stage 1 and 2 and 3 and 4 across different cancers, across different countries, even within a country at different hospitals. And so what they're doing is they're creating, not created, but it's in the process of being created, a model that can act almost as a translator from one data set to another and create a standardized version. If they can do this, then this helps provide better data to the model because we're no longer just using like one specific type of cancer diagnosed by a specific physician at a specific hospital. We're using a way more diverse data set, and then in theory we could get better, more scalable predictions. But it's something that's in the process. There's also other current digital health guidelines and standards for formatting digital health research, like FHIR and formatting images even as like DICOM files, which is just like a random JPEG photo on your phone. So we're getting there. But yeah, it's a huge need. I think the other aspect of what we need better input data on is that the labels or the outcomes are often expert evaluated, and like I said, they depend on like the clinician's ability to see that. So they're training, and before they train this model, they had a bunch of physicians go through all of these head CTs and say, I think this one needs surgical intervention, I think this one needs surgical intervention, I think that one doesn't. And then they train the AI model to do the same thing. But we have to move sort of a bit beyond that. And I can't recall exactly what they did, but there needs to be a look at sort of the outcome of that patient. So it's not just what the physician thinks, but then what actually happened, was it needed? Like, so yeah, better data on both fronts, what goes in and also the answer that we tell the model.
Yeah, thank you very much for that. I'm a professor of medicine at the University of Toronto, and it seems to be left out a part of this process, which is regulatory approval.
Mm-hmm.
Both the FDA and Health Canada, we're left with the impression that these algorithms are being created, they're being then deployed around decision making, and of course that's not the case.
No.
So I think you should.
Yeah, you are. Yeah, we
address
want
that
to
too.
talk in detail about that. I agree. We can. I realized we were running out of time, and they told me 45 minutes, and I was like, at the end, I'm like, oh dear, I need to accelerate. But I think that we are making huge milestones right now in terms of regulatory approval of the devices, and huge milestones in terms of like 24/7 monitoring of these devices that are deployed. And we often do a lot of silent trials before deployment. So that's what I explained with the AI tool right now that they're developing at St. Mike's. So there's a whole pipeline, and now I'm wishing I included the slide, but it basically displays how AI can go from development to in actual care. And so you have the data, you train the model, you test the model on a new data set. If it works, you then take it into the clinic, and you have to deploy it without physicians being able to see the output. And this they call silent deployment. And so then you see, well, is the model working with new data, with new people, in the right care flows? And if it does work, then you can actually move towards the next stage of deployment, which would be assessing how AI works when the clinicians know the answer. That's arguably the most challenging part, because you want to make sure clinicians are using the information, that they see it, that it's something that they can actually consult, and that it's still, again, helping to improve care. And then you would actually then move into like full deployment, where you would continue to monitor it. In terms of actual approval, though, like you can, in theory, develop a model at your institution, monitor it, and deploy it without Health Canada approval. You wouldn't then be able to sell it, but I would say that the Health Canada approval, where are we here? As a software medical device is becoming more and more common. People want this designation on their models to show that it has been approved. You would never, as an institution, like buy a model that was not approved. But there is sort of this move towards in-house development that's specific to your population, only deployed if it is being monitored. Do you have anything to add to it, though? I'm very curious.
Well, certainly on the commercial side, you need
Yeah,
Health Canada approval.
100%.
And in the US, you can't get any algorithms
No.
approved without FDA approval. So it's not as simple as, certainly my personal experience within UHN where I am, we cannot deploy our
Without-
self-generated algorithms.
Yeah.
Because of that barrier. So it's not as straightforward. I
Yeah,
think.
no, it's definitely not straightforward. I think the AI scribes, too, are also a good example of that, where they have had approval. They've been piloted across Ontario with different pilot institutions. They got feedback. They followed sort of that exact pipeline. I have heard of hospitals that piloting models. Again, piloting, not full-scale deployment without like Health Canada approval yet, but I don't know if that's outdated and no longer acceptable.
Well, I guess the point is that we would all collectively,
Yeah.
you do need oversight, right?
Yeah.
The idea that some cowboys are in a back room
No.
developing algorithms that are going to
Definitely
be made
not.
in decision. Well, you may
Yeah.
say definitely not, but that's
Yeah.
why Health Canada and the FDA exist in the US and Health Canada here.
100%.
Right, so-
And we are making very good progress on that front as like a country in terms of, I think the US was a bit ahead of us, FDA was a bit ahead of us on how they license some of these devices. But we've caught up.
I think we have time for one more question, and then I know our speaker has to drive back to Toronto, so here we go.
Thank you very much. I'm speaking as a patient, and my concern is, well, but specifically around physicians and nurse practitioners and their availability to us. I can understand if I was a physician overburdened, being expected to see a certain number of patients, and be aware of, on top of everything to do with that patient And I find that things are sort of lacking in that way too. You know, you can have all the information in the world, but if your physician isn't aware when you step through that door of the full story, you know, and whether this will help, I don't know. I would see it if I was a physician as just another thing that I have to do to meet somebody else's requirements. And the same thing in the hospital with the nurses coming round to the beds with the pharmaceutical pills. And my gut feeling has always been that they're kind of fulfilling a requirement, and maybe it's helping with survival, I don't know, but I just see them tied to all this technology. And this is just a more sophisticated thing, and I don't know whether the sophistication of this is applicable at the patient, general physician level, or whether it's something that would be nice to achieve, and there are people who do studies like yourself, and will, in the long run, maybe churn a lot more patients through with better outcomes and so on. But there's a limit to everything, and I just wanted to make that point.
Yeah, I think that's a really kind of thoughtful and interesting insight. It's like how this technology fits into the whole healthcare like procedure as a whole. And I think that when I hear that, like one of the things that comes to mind is the many different assets and aspects of AI. So AI has many forms, and it is just a tool. And so it depends, I think, on the instance, like what impact it'll make. Not all AI will actually improve how many people we get through the door. You know, some are helping prevent people from even needing the hospital in the first place. Like they're going more upstream. Others, like, so instead of just like dictation device where you speak into the phone and then it types the note that you said out loud, like an AI scribe would listen to the conversation and then create a note based on the information that was said in the conversation in a secure manner. It's not like ChatGPT. The information doesn't feed into another system. But that AI tool, which was designed to listen to the conversation, help write a note, and then not keep that information, that AI tool was actually designed not so that clinicians are focused on the tech and not on the patients, but to actually help the physician talk to the patient. Because what physicians were saying is like, you know, it's great to have this electronic health record, but I spend so much time typing my computer and I just want to talk to this person. Like, and so that was sort of the rationale and the use case for why they created the AI scribe. Something like the pager alert, obviously they're looking at the pager and then going to see the patient. So I think that each tool will have a different impact. It's again important why we're evaluating each tool and the impact, not just on like whether the patient survives or not, but whether it improves how patients perceive the quality of their care, whether it improves not just how many patients physicians get through, but how physicians enjoy the interaction with patients and stuff like that. So that is sort of the future of the evaluation, is not just like, you know, does it work or not, but is it improving what we decide is quality of care?
That's a really good place for us to stop. And I know you have time constraints, so I think we'll wrap up now. And that was a wonderful question. Thank you for that, and thank you for your response. I think it provided the I don't want to use the word closure, but the information that we really wanted to understand how this will help patients as well as clinicians and the system, because that's a reality. We need to find a way to treat more people in all different places. Gemma, I know that you are in a rush. I have a few comments I need to make to the group as a whole. So if you want to, Kathy wants to help you get on your way, I'll make my comments, but thank you so much for being here. Thank you.
It
was
this
terrific.
Awesome.
It's amazing to see what goes on behind the scenes with young people of your generation, even though the silent and the boomers, you know, may have started it. We're not doing what you're doing, so thank you for that. So a little housekeeping, if you don't mind. Before I let you leave, I'd like to, my name's Elizabeth, by the way. I'm the chair of NLC, and I forgot my badge, but I know most people, so I didn't think I needed to say that. But someone remind me that there might be new people here. Are there any new people here? There you go. Hi. Okay. It's the last event in our program on our digital health. We've had a busy year. I want to thank the people that make this organization possible. You probably recognize most of them, but you may not know them by name. So I'd just like to say thank you to Kathy Bennett, Kathy, who spoke to us first. David Kent. David, stand up. He introduced last week. I don't know where he's hiding. Oh, wait, there he is, David Kent. Peter McLaughlin at the table in the back. Yeah. Don McMaster beside him. Joanne O'Sullivan. And Barb Woolley. Where are you, Barb? Over here. And Wayne Lang is also on the board. He's in Montreal tonight celebrating a big birthday. So thanks to all those people and to our administrator, Nedra, who's not here, but manages the ticketing and customer service with amazing efficiency and humor. And I'd also like to thank our gracious volunteers who help at the door, Dina Johnson, Carol Copps, Barb Pemberton, and Grace Rivers, and to Gil Johnson, who has been manning the coffee table and keeping an eye on that chocolate. So thank you all for that help. We'd also like to thank Gord Burdick, who is the manager of the facility here. I think he's maybe watching the game in the back, but thank you, Gord, for always making NLC feel very welcome. Kathy and Linda, who are here tonight too. And Linda for her great question, as always, and Kathy, thank you both. 2-1 Leafs at the end of the second. We want to thank our AV heroes, Kevin and Joel. They are well known in this neighborhood. But most of all, I want to thank you, our loyal audience. 150 of you have signed up to be connectors. It was 149, and now it's 150. Wayne is going to be so happy. That's all he wanted for his birthday. That annual act of generosity makes a huge difference in keeping us afloat. So thank you again. If you want to find out more, the table is still open. And a reminder that as a connector, you get to go to the garden party on June 7th, and that's a really fun perk. And bring your friends. So the fall program is now taking shape. Just to let you know, before you leave, it's going to be called Food, Feeding a Changing World. We're examining what's on your table from many aspects: global trade, food security, how grocery stores respond to changing consumer needs, like buying Canadian, food culture, and the science of growing, like vertical greenhouses and how they can now make those strawberries in the winter in Canada, which is good. So this will be fascinating. We're hard at work getting that organized. We're also working on a couple of pop-up events this summer, so watch your email. And in the meantime, have a wonderful May. And thank you all so much for being here.